I'm Jan Lewis-Brandis with the National Neuroscience Group and an assistant clinical professor of neurology at Vanderbilt University. And now we're going to look at a disease model of migraine and the implications that using a disease model may have for both patients and for those of us who are caring for them. The traditional medical model of disease really requires three components. One has to have an abnormal state or an abnormal condition. And then the three pieces that are part of how one approaches the patient in that model are that the patient must come with discomfort, dysfunction, distress. And that is how the model really begins. A patient comes into a setting where we are the clinical providers, and that's the way we think of it, the medical model of essentially disease. That pattern looks at patients really as cases. So it's like, this is a case of, as we just heard, migraine, or this is a case of sinus headache that's misdiagnosed. It's been misdiagnosed as sinus and it's really migraine, or it's tension type headache, or the patient believes they have stress headache. So these patterns to the patient really are very important. But in the medical model, the traditional medical model, but to the patient, that person's really an individual, not just a case. This disease-based approach really doesn't include the more humanistic perspectives. It doesn't really include what that patient brings to their disease or to their abnormal state. And it can change the relationship by just diminishing faith. If the patient doesn't feel heard, that has an impact on the model. And lastly, but not least, certainly there's this rise of alternative medical treatments that are usually started not when things are exhausted, but often when not everything has really been offered to the patient, or perhaps they haven't understood why or how or when they should have done the treatment or taken the treatment or been part of a treatment regimen that really would work for them. So we see repetitive visits, or what we sometimes see is that patients really drop from care. How do we reframe this? Well, I would suggest to you that the disease model that's most helpful in a condition like migraine is one that is an ongoing process, and one that recognizes the fact that for many patients who come to care and who stay in care, migraine is really a chronic disorder. It often has fluctuations in its severity and frequency, and it often has a move toward chronicity. And those are pieces that really, I think, make us need to think about how we can reframe and move toward a patient-centered approach as we diagnose and design treatment programs. It needs to be very personalized, and we need to take into account how the individual views their illness. When they come with headache, what does that mean to them? And at the time we often see them, if we're seeing them as headache specialists or someone interested in headache, we will be seeing them much later in their journey or their essentially their path to us will have been made up often of many different episodes of headache and many different experiences associated with that. The art and science of medicine, much is said about that. There's a new TED Talk that really elaborates on this. We can know the science, which we must know, but there is an art, and that's where the patient-centered model really comes into play. If we don't include that component of the model, the science can be perfect. We often see this in patients who continue to see neurologists or who see more than one headache specialist. They all have, for the most part, access to the same medications, acute and preventive, unless someone's participating in a trial. Those drugs are available. They all have some of the same amount of time for that patient. The reason that some people get better and some people don't, I would say in general, or the reason maybe we can say the reason some people are successful in this model and clinicians are successful in this model is because we really look at the art of applying the science. We really have to understand who that person is, what's doable for them, how they feel about medications, how they feel about the behavioral aspects, and do they understand the disease that we know is migraine. So we have to really apply medicine, and I'm speaking not just medications, but we have to really apply medicine to the illness as this comes to that particular patient and the history that they've developed with it. And we really need to think about their social circumstances and the culture in which they live. If they have a mother who has always said you're weak, if you take something you should just power through it, as the phrase sometimes goes, that person will always be very reluctant to take medicine unless we've walked them through the process of why, when, how. If it's someone who has had a parent or maybe a spouse or a sibling who has become addicted to a prescription medication, say a narcotic, they may be very afraid of medications, even non-narcotic medications. We have to take those things into account as we begin to design or participate in a model that allows the patient really to be treated successfully. So how do we think about disease versus illness? Well, disease, of course, is really a pathophysiologic process. Something is wrong. We've just heard this very elegant lecture from Dr. Green talking about the pathophysiology as we currently understand it of migraine. Illness, however, is more than just pathophysiology. Illness is what that individual migraineur, that individual cluster patient, that individual with headache comes to us in terms of the complete person. Again, their physical state, what other medical conditions do they have? Are they in great shape? Are they an Ironman competitor? Are they anxious? What about the psychological, the psychiatric comorbidities? What is their social situation? Do they have an understanding of human physiology? Do they know about their bodies? Or do they have some idea, or do they have no idea about how drugs get into bloodstream and work? And then what's the cultural milieu in which they operate, both in their home and in their communities and in their workplace? So when we think about illness, we really have to think about what the individual brings to that and how they feel, what is their experience of being unwell. And in the case of headache, of course, that's what happens to them not only during attacks, but what happens to them between attacks as they may anticipate, dread, or be really in a state of fear about the next one. Well, there are lots of different ways that we can look at this. I do think the term web is useful because it really can be a web, and often when people come to us, the web is pretty well constructed. So what we really have to do is to look at the web and look at what their experiences and belief systems are so that we can essentially find ways to improve communication and to really have the headache patient be heard, understood, give them a climate in which they can go back and forth with us. And I don't really think, it's not really a true negotiation, but I do think that on some level, it is. It's the art of figuring out what that person is willing to do and then leading them, so there's a leadership component in it, leading them to a place where they can be successful and cared for, and their illness or their disease, depending on what term we use, really can be successfully managed. The explanatory model really is one that looks at their perception or their conceptualization of the cause of their headache, the course that they've had coming to us, and then as they continue to work with us as clinicians, and then the consequence of their illness. And the consequences have often been fairly grave for many people by the time they see someone who is really interested in headache. They may have lost a job, they may have lost a relationship, they may feel very guilty about their inability to take care of families or to perform as part of a social group. And so these are going to be very important components, especially as we assess the patient, and it needs to be really done, I would say, at every visit as an ongoing process. And it's important to know what's gone on before we see them, because I still will see patients who, for example, this is just a little just left in here because it shows you, if you see a 54-year-old woman who's had headaches since she was 8, and her understanding of the pathophysiology has originally been that she had beautiful, long, heavy hair, but she had terrible headaches as a little girl. If she was told, often by a physician, that if you'll just cut her hair, her headaches will get better. And that's done, so all of a sudden you have a young girl whose hair is cut that she loved, and then for the next 10 years she still has just as much headache, But again, what does that teach her? What has her experience been with understanding the pathophysiology of headache? So we have to take these early experiences, good, bad, sometimes indifferent, and really make them part of how we approach the patient. So exploring what the patient believes about his or her illness, that means exploring the things they've been told that are incorrect, and gently walking them through those and pointing them out. What are the causes of the illness, and how willing are they to try new things? I think it's very helpful early on to say, tell me what your expectations of this visit are. Tell me what you were hoping I would tell you. If you don't sense that that's where that you and the patient are really on the same level in terms of communicating about what they're telling you. So it's important to really understand patient beliefs, why they think what they do, and are they willing to try or take new things. And often I think they are. It's rare for me to see someone who is not. If they have a clear understanding of who and what you are and your approach to illness, and that you are really partnering with them. So the model is really patient-centered, but the patient may be in the center, but we as the clinicians are really directing it. And building trust is very important. So if someone only can do one thing after an initial visit rather than 5 or 6, that may be the way we do it. Other people will be able to do multiple things and follow very complicated regimens, but some people really will not. We have to really try to avoid the stereotypes that are so often there. I'll often hear at a headache meeting, people will talk about the so-called drama queen of headache, the person that comes with the big dark sunglasses, lots of drama, and all of the sort of, oh, I've been on everything, oh, I can't do this, I can't do that. And what we as clinicians need to do is to wade through those stereotypes, is to start to treat that patient with respect and dignity and listen. And take that history and find out what happened to her as an 8-year-old. What have been her experiences that have led her to this place? Because often those external things are a signal or symbols of a hypersensitive nervous system, but it may be layered over other experiences that she has had. For example, it may be layered over childhood maltreatment. So it's our role to really avoid the stereotype, find and build trust, and really deal with frustration and anger, because often patients have been told things that have not worked out. They may not feel they have a partner in their care, and they may be angry and ready to take it out on us, and that is really where professionalism and I think care for the patient come into play. And then we move to this effective and honest negotiation. What are you willing to do? I'm willing to support you clinically. Let's do this together, and let's figure out something that works for you. Certainly, good communication and trust, we know from any number of studies in any number of disease states and in any number of disciplines in medicine, if you don't communicate, if you don't have good two-way communication and the patient doesn't trust you, you are very unlikely to have the same sort of outcome. It doesn't really, we all have the same medicines, whether we are a family practitioner, a nurse practitioner in neurology, whether we're a gynecologist. We all have access really to the same medications, again, outside clinical trial medications. And yet, why do some people do so much better in the hands of some providers and some patients do so much worse? And I would suggest to you that communication, trust, and encouraging and moving the patient forward have a great deal to do with the ability to partner and to make that relationship one of caring and trust that is based on the science of headache. When we think about how this model, if we think about those patterns as models, and we think about what's happened over time, these are older data. Mark Green just showed you some of these concepts looked at in the late 90s or the late 80s and then the late 90s. These are from the American Migraine Study 1 and 2. And if you look at the number of patients who've consulted for migraine, it's about 34%. So not a big difference in terms of people who never consult. Remember, there's something very important between or over this decade, and that was the introduction of the new migraine-specific therapies. the so-called triptans. So here we had drugs that worked. They got FDA approval. They were available in injection and tablet and melt and nasal spray. We knew these drugs could work for most patients who if there was no contraindication, and yet we didn't see people just rushing out to get them. Now, part of that has to do with what Dr. Green just told you about. Many people, if you believe you have sinus headache, it's probably not until it gets so severe, or you may have taken an antibiotic and a Medrol dose pack for 15 years, and someone finally says, this is just not working, or maybe a new primary care physician comes in and says, I don't think you have sinus headache, or maybe you get sent to a talented ENT. The neurotologist at my institution, Vanderbilt, are very great about saying, this is not sinus headache, this is likely to be migraine. So it's not entirely clear why those are, but again, major advent of medication, the science really improved in terms of treatment, but consultation did not. Look at the current consulters, again, that did go up, which I think is a reflection of in part, the level of education for both providers, and there was much more in the lay press about acute therapies. But look at this number. So we have reduced lapsed consultors, but look at these numbers, and even in the hands of in the hands of providers who have now had triptans for a decade, we still see lapsed consultors. What does this mean? This means they're not going back, they're not receiving effective therapy. Why do people either not consult, or I would suggest that some of this may also be why they lapse? One is, I'm familiar with my condition. I know I have sinus headache. I know you, the clinician, thinks that it is migraine, but you're wrong. The previous visit to the doctor was unsatisfactory. Again, that speaks back to the model. If the model is one where the patient feels heard, even if it's a brief exchange, even if it's not the luxury of an hour and a half, that may be part of what it is, why people don't go back. So we need to really think about that. The doctor was unable to do anything for me. And if we can't get patients to adopt some of the strategies that we think are likely to help them, then they are not going to feel we have anything to offer them. If they think that their preventive medication has to work in 4 days, that sets them up for failure, and us as clinicians up for failure. So we have to really look at these, and I think this is where the changing model can be very important. Over-the-counter treatments work for me, and that's, of course, the hallmark of how people get into medication overuse headache. They get up in the morning, they take their 2 analgesics, they beat the headache down, they get through the morning at work, they repeat it at noon, they beat it down, they get through their afternoon, then they're home. And again, over time, that can transform them into chronic migraine, of course. So they have headache all the time, but they may be more functional, so they essentially sacrifice ever getting pain-free for some measure of functionality. It's only a headache. If you're in a family of migraineurs where some of the migraineurs are in bed with their headaches and yours don't put you in bed but they just make you miserable, you may not think that it's valid for you to be treated. My dad's are so much worse. My sister has terrible migraines. They can't be migraines, because when someone has a migraine, I remember my mother, she would lie in bed for days. Those are the kinds of belief systems that, again, if we don't tap into and understand, we may have patients either not coming or who don't really want to stay with us. Mark is a patient of mine that I saw as an adult. I'm an adult neurologist, as an adult, but then I went back into his history at the first visit. When I went back into his history, it turns out that he began having headache when he was about 2 years earlier, when he was about 5. It was in the front, in the maxillary area, so you just heard from Dr. Green that afferent trigeminal system can certainly be involved in migraine, but it was in the front and over the areas of sinuses, and he described it as if someone was sitting on his face. At the time I saw him, he was 37. When people remember a descriptor like that for 30 years, it's almost like giving you the diagnosis. And it's also like having someone say, hear me, No one listened to me when I was little. So it was before the days of recognition of Reye syndrome, so he was given St. Joseph's baby aspirin. His parents both had headache, and they said, it's just sinus headache, we have it too. And when they went to the physician, they took him to his pediatrician, sure, it's sinus headache. So here's the beginning of a wrong model, I would say. You have a child, he's not heard, he's not listened to, the diagnosis is missed, no one's listening to his explanation of severity, his parents are diminishing or minimizing his symptoms, his discomfort, ultimately his dysfunction, and again his distress. Patterns of medication use for migraine in the U.S. also over time have not changed appreciably. So for any prescription drug, that would of course include the new triptans from 89 to 99, and then over-the-counter meds exclusively. So almost 60% of patients who believe they have migraine use over-the-counter treatments. And then look at the ones who use nothing. So that's actually stayed about the same. I guess you could say if you look at total numbers, it's in half. So one wonders whether or not that means that people tried the newer medications and then again tried some of the prescription drugs and then wound up not staying with them. And one of the issues related to that is often instruction about how to take the new drug. If we think about sumatriptan, when it was first introduced as the injectable, it had efficacy data at 10 minutes. So it was an enormous advance. But patients were often given the injection and told to take it at home. And if they hadn't been warned or told about the triptan side effects, often the chest tightness, jaw tightness, lightheadedness, pressure sensation, if they hadn't been told to watch for those, that they were a normal part of this drug side effect, then many of them were frightened, would go to the ER thinking they had a cardiac issue, and many of them would never try the drug again or never try triptan again. So we can see how, again, communication and good instruction and understanding can make a huge difference, because what's the major issue that we deal with here is, again, often medication overuse, and it may allow the patient's underlying primary care disorder, certainly in the case of migraine, to progress and become even harder to treat. So this is what happens to Mark when he wasn't heard, when the model didn't work for him. Now he's 17, he's still having 2 to 5 of the sinus headaches a month. Now he's beginning to really miss activities or school because he has more activities now. He wants to play basketball and he's missing academic work. And now his pattern has changed a bit. He has more of a tension onset, as Dr. Green has told us. It's more of a pressure. It's really bilateral, it's band-like, and he often has the neck pain that we can see in about 75% of migraine attacks. So he's changed his pattern a little bit. He's still having the more severe, quote-unquote, sinus headaches. And now, because of the dysfunction that he experiences with his attacks, he's had to drop out of basketball. We know that exertion, for many patients, exertion tends to help tension-type headache. But one of the criteria, not the sole, but one of the important criteria for migraine is headache that's made worse by routine activity. Certainly basketball would be more exertion than that, and he finds it worsens his headache, so he's had to drop out of basketball again as a junior. He was told when he went to the doctor it was tension headache, given Soma and Flexeril, those branded names. Now where does the model fail Mark? Again, it's missing the fact that he's missing activities. He's telling them that his pattern has changed. He's telling them dysfunction, discomfort, and distress. And that's not being heard. So we don't hear that. So again, what are his choices? It's easy to see how someone like Mark could become a lapsed consultant. Well, what do we know about Mark? Ann Shear, an epidemiologist at the Uniformed Armed Services Medical School, really many years ago did work to show this case control study to show or to identify what factors are really involved with transformation to higher frequency patterns of headache. And what she found was that attack frequency was very important. There's some other things that she found, but attack frequency was very key. If you start out with a higher attack frequency, you're more likely to have more headache and to progress to chronic headache, in this case chronic migraine, more than 15 days a month. Being a woman is also on the list, again because of the hormonal influences. But attack frequency for Mark was really there. Medication overuse, he was having to use more and more over-the-counter medications. Stressful life events and childhood maltreatment. Again, he did not turn out to be someone who had had childhood maltreatment, but we know from work that has been done through our clinic, published under Gretchen Titchen et al., showing that if someone has childhood maltreatment, they are much more likely to have more depression, and those are the patients who are at higher risk for very severe, chronic, debilitating migraine. Those would be the patients, we have to think, who may come into our offices with these very dramatic appearances, these very sort of catastrophizing approaches to their migraine. But again, what's underneath that? It's a belief system, it's injury, and it's injury in reality to central nervous system. We know that over time, that persistent childhood maltreatment can actually produce a state in brain that alters the hypothalamic pituitary axis. Those patients have persistent cortisol release. They can actually remodel brain structures, and as those are remodeled, they may play some role in the patient's ability or inability to shut off pain. So there's some very interesting work going on with this, and of course, head injury in today's world is a very important source as we now look at all the patients who are coming either from professional sports, for amateur sports, and just from head injury in the United States in general, certainly from military injuries. Head injury increases the risk that someone will move to chronic daily headache. Snoring is on the list probably because it relates to because it is related to an increased body mass index, and that also was found. Mark didn't have that, but Mark was found to have, he didn't have snoring, but an increased body mass index is one factor that's involved in transformation, and it may be through release of pro-inflammatory mediators. That's not completely understood. What happens to Mark now? So we're about 11 years later. So this is a person who's not been heard. The system is not paying attention to him. So now he's a grown man. He's still having those patterns of frontal, much more intense headache. Now his headache, his newer pattern that he had at 17, has become daily. So he's evolved. So he's gone through Dr. Shear's pattern. He was a high-frequency person in the beginning. He was under stress. Again, all of these factors, he had analgesic overuse, medication overuse, headache, and now he really has it. He's taking 8 to 10, 8 to 12 Anacin or Tylenol a day. That's so he can function. That's so he can work. He now has allodynia. So this has gone on long enough that he's not only peripherally sensitized, but now he's centrally sensitized. So he has this tenderness to touch. And despite all of that, his belief system in himself and trying to move forward is really there. He's gotten married, he's finishing up his MBA, he's working full-time. And the phrase that he uses is learning to live with headache. Well, learning to live with headache is, in that context, I think, exactly why we have to rethink the model. Because what we want to do is, if we have exhausted all possibilities, or we have someone who really cannot participate, but Mark is so far from that he's not atypical from patients that anyone will see if they're seeing a lot of headache patients who have higher frequency and who've had higher frequency attacks and who've had them for years. So what about these patients? What happens to these patients who have the so-called unmet treatment needs? Well, again, the thing that often brings people to attention is usually the fact that they cannot function. They may be losing jobs, a relationship may be in trouble, they really may be having to have parents come and help them, older children help them, they can't cook dinner, they can't go on bike rides, they miss birthday parties, they miss work. So severe pain, if the attacks are occurring frequently enough, and they are disabled during the attacks. And we know from the World Health Organization data that during an attack of migraine, that is classified in the top 20 of the most debilitating conditions by WHO. So of the patients who don't come for consultation or who have lapsed from consultation, it's not as if they're lapsing or not coming because they're doing well. 61% of them have severe pain, and 2/3 of them have severe disability, often defined as the need for bed rest. So this is a model that's broken, because this model, we shouldn't be having people do this when we have the treatments available for patients and when we really need to engage them in what for most of them will be chronic disease or chronic illness. So this is actually when I saw this young man. He was 37. By this time he had essentially completely transformed into daily headache. He has both the features, the bifrontal, bimaxillary, more severe pain, and the tension band-like features. Now he's really struggling. He's often unproductive. He has just lost a promotion, not because of his talent, not because of his willingness to work, not because of his capability, but because he cannot function. So now he's really stepped it up. He's taking daily Tylenol, Excedrin, and Soma, again, every day, anywhere from 4 to 18. And finally, I always find it interesting to ask patients why. He's had headaches since he was 5, so he's had it for 32 years. Why now have you come for treatment? And he said that his 5-year-old son came up to him and said, asked about going out to play ball, but he said, "Daddy, do you have a headache? You always have a headache." And that was, okay, is there anything else I can try? And that's where we need to really encourage people who have not been in essentially a disease model that works for them. The disease model has not worked for this young man, and that's how we as clinicians can really begin to assume the responsibility for directing and driving the model into one that really works. So the patients have all these choices. There is sort of a maze or a myriad of things that are out there, but we can't just simply give someone a bag of acute medicines or a bag of preventive medicine. We really as clinicians need to hear, to exchange, to talk about what patients' lives are like, what their sleep patterns are like, their food, their nutrition, their hydration, and what pressures come to bear on them. And then we need to choose, again, based on those issues, and then also on the nature of the attack. Just as Mark has some smaller attacks, he has the daily attack, he has moderate attacks, he has very severe attacks, we have to really make those choices, because it really is somewhat of a maze for patients, and they can't be left on their own and be expected not to drift into medication overuse or into nothing, which means that they often have a downward spiral in terms of their capabilities and what they really want their lives to be. If we think specifically about medication overuse, 80% of patients with chronic daily headache have this pattern. The majority of them are migraine, because that, again, is the more severe of the migraine and cluster, or the most severe patterns. Cluster, of course, if it's episodic, doesn't occur except in cycles traditionally, and so it's migraine that really poses the greatest risk for transformation into chronic medication overuse headache. It's a female preponderance, as we know, for migraine, that bears through. Dosage and time to rebound are really unknown. It's not really known how long exactly do you have to overuse or frequently use a shorter acting acute medication before you move into medication overuse. But it would appear, I think, very clear that it takes a while to change the headache. The older to change it, to push it back from chronic migraine to episodic migraine, which is really one of the important goals of treatment. In the past, one of the strategies was simply in some large headache programs, was simply just to stop all the analgesics and just tell the patient they had to get worse before they could get better. And if you think about the pathophysiology of medication overuse on top of the pathophysiology of migraine, we know that that would seem very unlikely to be effective, because people don't just start, pushing their cart down the Walmart aisle and going, I'd just like to get every analgesic on the shelf so that I too can be someone who takes 18 Advil a day or 18 naproxen a day or 22 Excedrin migraine a day. The reason people do that is because they have headache and they want to function. And that's how, as the headache progresses, if we don't prevent and put their brains in a milieu which can support enhanced brainstem tone and essentially homeostasis, then they are going to be at risk for that. So there's not consensus on this. The general considerations are here. There are very formal ones that are available through the International Classification for Headache Disorders about strict numbers for these. But I think when we're taking care of patients, it is the trend that's important. Simple analgesics more than 3 to 5 days a week, the triptans more than 3, ergots opioids more than 2. Again, most patients will be using a combination of these things, or often will be using a combination when they see us. And what are the implications of this? Again, when we think about public health issues, it's not just the individual patient and the model of health that's important, but look at the numbers. $3 billion a year total for over-the-counter analgesic use in this country. $1 billion of that, a third of that is for headache, and these are not brand new numbers, so I'm sure it's even more now. Look at aspirin use in the U.S., 16 tons a year. I would say probably more now for headache, and look at the complications of that. Hospitalizations for GI, arthritis, renal failure. So the consequences of medication overuse really are not only the transformation of headache, but can include quite serious and quite permanent other medical conditions. I participated a number of years ago in something called the Maze survey that we did across countries, and we were very interested in trying to see in the Western world population, since there was a better understanding of migraine and new migraine-specific treatments had been identified, why we weren't doing better. Because people were continuing to have disability, they were continuing to have inappropriate management. And what we found was that medical consultation rates, despite the advent of acute migraine-specific therapies, were still lagging behind. And look across the board. So this is France, this is essentially the European Union and the U.S. And you can see the percentage of headache sufferers, again, these are the consultation rates. So across Western nations, we still have, even with better drugs, we still don't have the kind of consultation that you would expect. So there's this disconnect. We have better and better medications, both acute and preventively, for essentially for treating migraineurs, but we have this, essentially the bridge gets broken and we have patients who are remaining at bed rest. So what we have to think about is, in the model, creating individualized care. Again, are there many parallels between patients? Of course. But we have to think about how can we really optimize the care for these individuals who come to us. So one thing is to match the severity to the treatment. That may mean take this for your smaller headache, take that for your moderate headache, do this for the headache when you wake up and you're already having nausea and vomiting. It may also involve teaching the patient sort of self-soothing, and by that I really mean self-soothing their hypersensitivity in terms of their migraine brain. It may include things like being very careful about sleep. If you're stacking triggers, we know that when a woman's estrogen level fluctuates, the drop that she may experience as she begins her menstrual cycle or the rise at the end of her cycle, that fluctuation in estrogen is going to make her brain more hyperexcitable, and she will be more vulnerable in a brain that already has issues, or we will say has the predisposition or the susceptibility to hyperexcitability. So we want her to be particularly careful about sleep, hydration, avoiding alcohol during those windows of vulnerability. So again, teaching patients, it doesn't always have to be about medication, but we need to think about illness severity. And we may need to be more aggressive with pharmacological therapy in the beginning, encouraging patients that as they begin to control behavioral components, sleep, hydration, diet, then they may be able to be on less and less drug. And again, for many women, parallel to that will be management of their the hormonal component of their headache. Teaching patients how to take medications is critical. If you, when sumatriptan nasal spray first came out, the instructions were to lean back and spray it. If you leaned back and sprayed it, it had a large droplet size, it would drop into the back of your throat, it tasted terrible, and people swallowed it, turned it into a tablet, and it didn't work. And that means that if that's a medication you're going to have someone use, they need to lean over, make sure the nostril is clear, put the device in the end of the nose, spray it, hold the nose, hold the breath. You want to get it absorbed in sort of this mid region of nasal mucosa. If they're going to take the tablet when they already have gastroparesis, that's unlikely to work. If they wake up and they have nausea and vomiting, you have to have a non-oral route, injection, perhaps a patch. They may need to have a suppository for the vomiting component. So we have to teach them how to take it. And I'm a huge believer as the clinician, although I do it in partnership with my nurses, but I show them, I demonstrate how to take the medication, and then we write it down and give it to patients. Those are important things because they teach the patient that you care about them, that you understand, and that you're determined to get those individual attacks under control. So we have to think about attack characteristics, how quickly, what I call rise time, how quickly from the time the headache starts until it's at its worst. If that's 10 minutes, you have to think about what you're going to give the patient because you may need to use different, more rapid acting and drugs that get in much more quickly. Is the patient disabled with the attack? Hormonally influenced migraine, a large topic in and of itself. Again, but we have to take that into consideration because if someone's been placed on an oral contraceptive pill and that's when they had their first migraine aura after going on the pill and the headache is transformed from episodic to chronic migraine on the pill, one of the first things we might do would be to take the pill off. I continuously hear women who say, I told my doctor that, or I told my nurse practitioner that. I told them I thought it was the pill and I wanted to come off. And they said, oh, they didn't think that's what it was. Part of the model is listening to the patient and, again, reinforcing what is real and what is true for them and then adapting it to the science as we understand it. Coexisting conditions such as depression, we know that depression and anxiety disorders have they're bidirectionally comorbid with migraine. Very important because if you start with depression, you have an increased risk for having migraine, and if you start with migraine, you have an increased risk for depression. So if we don't treat them, even though they're different conditions, they share many of the same neurotransmitters. They often tend to have similar patterns of transmission in terms of the genetic component, and we must treat depression and anxiety if we ever expect migraineurs to really do well. And then looking at unhelpful behavioral patterns. It's not uncommon for someone to be in a headache clinic who will get up in the morning, smoke a cigarette or two or not, drink half a pot of coffee, go to work until 4 o'clock, 5 o'clock that afternoon. They will have had coffee breaks during the day, maybe a pack of peanut butter crackers, maybe cookies, maybe fast food, maybe nothing. And then they have a big heavy dinner and they've had perhaps sweet tea if they're in the South, sweetened tea, or they may have cola. They may be drinking Mountain Dew throughout the day, or Coke throughout the day, or coffee throughout the day. So they may get anywhere from 64, sometimes 80 ounces of caffeine. They come home, eat a big meal, and then the headache, they've beaten it down because they've continued to take their short-acting analgesic. They come home, they finally drink more caffeine, and then they go to bed. They go to bed, they can't sleep, so then they load up on things to help them sleep, and then they get up at 2 o'clock, 4 o'clock, 5 o'clock. Those patterns we have to ask. People are not, in my experience, people are not going to volunteer in the model. That's part of the history taking. People are not going to volunteer that they're doing things that they may or may not really realize may be deleterious to their migraine treatment. So we have to ask them. Do we ask them kindly? Do we ask them gently? Do we ask them in a sort of matter-of-fact but informational gathering way, yes. So we say, how much caffeine do you drink? And remembering that not everybody recognizes that every beverage they drink is caffeinated. So how much? When do you have it? When in the day do you have the last? And that's how we can really correct things that are very simple, but we can talk patients through it and then make concrete recommendations. Drop your evening caffeine, then nothing after 2, then nothing after noon. Again, we're teaching the patient how to do it. We often give them very specific guidelines in terms of what to eat. They need to have some protein for breakfast, complex carbs. They don't need to eat 3 donuts, drink 4 cups of coffee, and have the drop in glucose, which often then can promote headache. So again, getting that feel for the beliefs of the patient, their patterns of life, their patterns of, I'll say, just daily existence that can play a huge role in this are absolutely critical, because if we give them perfect drugs, perfectly chosen, we still can have outcomes that we do not want because we have missed some huge component of comorbidity, of the attack itself, coexisting conditions, the role of estrogen, or again, simply behaviors that make headache worse by influencing the hyperexcitability of brain. Only about a third, only about 30% of migraine sufferers are really satisfied with their acute treatment. And why? This is again the work of Richard Lipton and Buzz Stewart. It takes too long, it doesn't get rid of it, it doesn't always work, headache comes back, too many side effects. And again, how do we go about managing these patients? The model suggests that if we talk to them about the acute medicine and teach them how, when, and why to take it, and the fact that migraine in adults is a 4 to 72 hour process, if they treat and don't completely get rid of the attack, it will come back likely. So we know that they may need to be on medications that have higher or that have lower rates of recurrence. We may need to stack medications. They may need to have an anti-inflammatory with the triptan. If they're on triptans, they may need to have an antiemetic. They may need to redose earlier. They may need to dose earlier. And again, we really need to teach them this dissatisfaction. I would suggest to you, in a correctly applied model, most of the time can be completely overcome, but it does take time. One of the barriers that we continue to have is that many people still think migraine is a woman's disease, that it's because people are too stressed or because there's something wrong with them or because they don't handle stress well. There are many mythologies about migraine, and happily we are moving further away from that as we understand more and more about the pathophysiology of migraine, and as we have treatments that are remarkably encouraging essentially in the pipeline. It's not life-threatening, so that it just makes you often wish you were dead. So the fact that it's not life-threatening often means that it does not have the same stature as many other diseases, and that's certainly important and that's certainly valid. There are no objective tests, so unlike treating temporal arteritis or giant cell arteritis or diabetes, we don't have, or hypertension, we don't have numbers. But we do have diaries, and that really remains the most effective way to really gauge treatment and patient engagement. Again, the perception of it as a woman's disease continues, but certainly there are millions of men, more than 8 million in this country, with migraine. Many people never go. Again, part of that has to do with family beliefs and family structure. It's amazing how many adults, adult women and men, are still plagued by what their parents have told them or forced them to believe, or created a climate which encourages them that the diagnosis is not migraine. They may be embarrassed. They may think that headache's just not as important if they have a friend with breast cancer, or they have a friend with multiple sclerosis, or they have a child who's really ill. So they may think, oh, it's not that bad. Again, how does their family approach disease? They may feel there's nothing the doctor can do, or the nurse practitioner, or the PA, because the previous ones haven't been able to do it. And again, it may be that they have a real fear of medications. You're just going to give me a ton of medicines that won't work like the others didn't, and I'll have lots of side effects. The other concern may be that the medicines will be taken away. That's particularly true if someone's put them on benzodiazepines for their comorbid anxiety. It may be true if they've been placed on opiates. through someone who really is not looking at managing the actual pathophysiology of migraine. So those may be reasons that they may not want to consult. So this is sort of another list of reasons why consultations can be ineffective in the old model and why patients may lapse. Many times as clinicians we feel sort of, I think, burdened. Oh my gosh, here it is, let's go through it. What I would suggest to those of you, and clearly anyone sitting for the advanced qualification exam is very interested in headaches, so I think this applies less to us. But what I would say is that remember that may have been the patient's experience with previous clinicians. So we have to, in effect, really reestablish the fact that we do care about them and that we understand this disease state or these disease states, and we're going to work hard at it. So we obviously have to reassure them after we exclude secondary headache. And again, patients want information. One of the things that I am constantly I feel very affirmed by, but I also find a little bit disconcerting is that at the end of a new patient interview, the patient may say, "Thank you so much for spending this time with me. Thank you so much for listening to me. Thank you so much for hearing me. No one has spent this much time." So granted, headache specialists do have the luxury of more time, but even in 10 minutes, you can help someone feel heard, and that is the key to the model. Reassurance, good communication, and application of the science is how we have better patient outcomes. So patients want pain relief, but they really want accurate diagnosis, and they need to be part of that. They need to accept the diagnosis. They need to get to a place where they really understand it too. And again, we can use step care, believing that it's safe and cost effective, but everyone who comes to see us will have used step care before they get to us. They will have taken this. If that had got worse, they move to the next step. If it got worse, they move to the next step, with the emergency room or convenient care centers being at the end of that step care pathway. So what we have to do is take them off the stairs and put them all on one level, in effect, and really teach them how to treat their attacks carefully. The comorbidities of migraine are really important. We have to take them into consideration, particularly when we're recommending things in terms of exercise, when we're recommending preventive medications, when we're thinking about sleep. Again, sometimes comorbidities offer us the opportunity to use one drug for 2 conditions or 3 conditions. I would suggest to you that that is not always the case. And if that's not the case, that we need to explain it to patients. There are 2 anti-epileptics that have FDA approval for migraine, which are obviously also for epilepsy. Those are topiramate and valproate. Again, those both have a dual FDA approval. We have to always think about stroke in women. There's the increased risk of stroke in migraine, and higher in migraine with aura, higher in women who are on birth control pills and who smoke, highest yet in that group. So we need to think about controlling for that, for those stroke risk. And then other medical disorders, particularly we'll talk a little bit about irritable bowel syndrome. It shares a number of sort of the hyperexcitable gut and the hyperexcitable brain are often viewed as being as having parallel underlying pathophysiology. The anxiety disorders, depression, childhood maltreatment being a huge and under-recognized cause, or I should say perhaps the start of migraine in children. If they have one of the genes for migraine and then they have childhood maltreatment, that is the young person who's likely to evolve into a very refractory pattern of high-frequency debilitating headache. Again, very treatable, but it has to be done in an integrated fashion and often needs to be done with psychiatry and certainly in some settings also with supportive psychotherapy. Specifically, and this is work that we did in our clinic a long time ago, you can see here, this is sort of migraine -1. So migraine without aura, if we looked at the incidence of depression and disability, again, here's depression, here's disability, you can see it goes up if you look at the total. So look at these numbers, the grade depression scores, the percentage, again, these are really much higher scores. Again, the disability here is much higher in patients who have migraine than in patients, again, who have either migraine sort of -1. And what about comorbid potential disorders? So there are many: chronic fatigue, major depression certainly stands out, fibromyalgia, late luteal dysphoric disorder, IBS. So again, we need to recognize they're there, but the major comorbidities for migraine are really the ones that are the most likely to give us challenges treatment-wise are the psychiatric ones. Now, what's happened with a lot of these patients who, in the current disease model? Well, we find, and this is work from an American migraine study, it was essentially to look at the need for preventive care in the U.S. And what it found was that 40% of migraine sufferers are candidates for prevention if you look at the numbers very conservatively. So again, here, only about 3% of the candidates are offered preventive treatment. About 1.5 has it even been considered, and I mean by the clinician. 4.5 sort of the total of prevention candidates. So only 1 in 5 people who have either disability or high frequencies or both in this country at the time this study was done, only 1 in 5 actually are on preventive care. So that's again a place that shows us from essentially a broad-based population study that we really are not doing what we need to change or adapt the model. And again, if we think about patients and how they took it, look at the numbers. So currently taking preventive medicines, about 13%. In the past 3 months, they tried it, didn't stay on it. 3 to 12 months ago, within the past year, about 5%. 12 months ago, about 10%, never took. So either they took it and quit, or they never had it. So again, we have to think about how that patient comes to us and how we redirect and re-engage. If they take it, this is a study looking at the use of one FDA-approved preventive for migraine. Topiramate happens to be the one that was used. In patients that were studied 6 months before the drug was started, and then 6 months after initiation of topiramate. And now look at what happens. Let's think about this in the broader model, not just to the patient, in essence to the patient, but also what happens to their families, what happens to the expensiveness of their care and their own healthcare expense. Triptan use goes down. Emergency services are cut almost in half. Diagnostic procedures go down. Hospitalization in half. Their office visits are up a little bit, but much less expensive than all of these other things. And it means that patients are functioning. If they're not having to take their acute medicines, that means they're not having attacks in this particular setting. So again, teaching patients the goals of preventive therapy may be absolutely critical. Again, this extensive use of acute and prophylactic medications 6 months prior to therapy, medical research use was high. After initiation of therapy, they dropped ER visits, hospitalizations, other medicines. Again, it's cost saving, it's life enhancing, and again, it reduces the hyperexcitability that, if we continue to let the brain continue, may set the patient up for patterns of chronic and increasingly difficult to treat migraine. There are many barriers to care. There are people who need it, getting them in for consultation, getting the diagnosis correct, and I would say correctly diagnosed and accepted, have the patient accept the diagnosis. Then working on effective treatment, which may take a while, and really essentially including physician and patient education, and continuing to work on education for not only physicians, but for nurse practitioners and for physician assistants. That's how we really get to good outcomes. And again, clinic-based screening may be helpful. Public education, I think, is always helpful. But what we need to really look at is moving the model between physician and nurse practitioner, PA, and patient into a place where we really can change individual patient outcomes. And since migraine is a genetic disease or disorder, that means that those individuals who are successfully treated are much more likely to have their own family members, their children, their aunts, their cousins, other people in their family come. When we think about why models are important, what we're really trying to do is change this disorder we know as migraine. Increasingly, this is work from Rami Burstein's lab. Increasingly, there's a recognition, and as Mark Green told you, it's not entirely clear where the so-called migraine generator is. But we know that messages go over time. There are many that go to thalamus, and as the second order neurons get activated, we have central sensitization, and again, allodynia, which the patient experiences, that I don't want to touch I don't want to brush my hair, I don't want to wear a cap. Again, if that continues, ultimately they get to the point where they don't want to be hugged. And we know that triptans, if used late in that process, will not overcome central sensitization. There are any number of inputs, and again, from brainstem to hypothalamus and back to the salivatory nucleus, and then the sphenopalatine ganglion, and again, then the messages go up. So if we think about hypothalamic input into the SSN, then to the sphenopalatine ganglion, and back up. So we've got afferent trigeminal messages coming into brainstem, into the essentially into the spinal nucleus of 5. So we have, and that can be a much longer structure than is really portrayed here. And then again, the hypothalamic input that then in turns goes through SSN into the sphenopalatine ganglion and then back up to these extradural vessels. So we know that when that wave of spreading depression or activation comes, it hits the PL arteries surrounded by these trigeminal afferent terminals. We get this release of the inflammatory substances. Dr. Green has walked you through that. But we have this sort of state where it would appear that these connections are really critical in maintaining homeostasis for brain. So if we, again, this is very cumbersome, but look at all the neurotransmitters that are involved. Glutamate, certainly being an important, maybe the most important hyperexcitable or excitatory neurotransmitter in brain. Again, but look, GABA's involved, serotonin, histamine, multiple ones are involved. And look at the input. So here's hypothalamus represented in a different way, and this is feeding back into the trigeminal nucleus. So we have connections between midbrain, again, spinal tract of 5. The upper cervical input is represented here. So you have all these inputs that converge into the trigeminal thalamic neurons. And if we think about, I want you to look at this model. If you really think about this, I think Dr. Burstein and his colleagues have put together a very fine concept here, because when we think about we sometimes talk about the migraine threshold, what sets that point, it's important for us as clinicians to really, I think, teach patients, and I think this is a beautiful model to think about how that migraine threshold changes. So we have all this going on. If it's going on perfectly, there's a state of homeostasis in brain. If you have enhanced brainstem tone, this migraine threshold represented here is the little red dot. So if you have enhanced brainstem tone, if all of the neurotransmitters are essentially in balance and you have appropriate input from the hypothalamus, again, in through the sphenopalatine ganglion, you've got this all, everyone is behaving, so to speak, from a hyperexcitability standpoint. So the threshold is down in settings of enhanced brainstem tone. And in that setting, if someone is sleep deprived, or maybe there's a change in the weather, the change in the barometric pressure, or maybe they have had 2 glasses of red wine, that patient may do absolutely fine, because the peripheral, the external input will be faced with enhanced brainstem tone and a lowered migraine threshold. So as long as this is really stable, that may be the case. But when when there is diminished brainstem tone and these messages are going for thalamic input, and you're having this convergence and things are unstable in terms of the neurotransmitter and the hyperexcitability component, then the migraine threshold will be elevated. And in this state of diminished brainstem tone, any external force can come in and make the patient vulnerable to the wave of cortical spreading depression. So everything we do, and having patients understand that there really is a pathophysiology here. There really is something wrong with brains. It's not because they don't handle stress. It's not because they're, it's not because they're not great people. It's not because of their personality disorders. It's not because of those pieces. It's because they have a change in their hypersensitive brain. I'm not terribly enamored of the hypersensitive brain concept. I do think we have to use it because I think at times it implies that people are sensitive to things. So if we use that term, we have to be really careful to explain it. I like the notion of enhanced brainstem tone or enhanced excitability. So we have this enhanced excitability that's really genetic for the most part. Many different genes, of course, have been mapped. Many different genes can be involved. But when we have a brainstem and a thalamic system that are working in concert and are stable and we have good homeostasis in our brains, then we are very likely to be able to shut out other outputs or other inputs that are coming in through that system. But if it's diminished for any number of reasons internally, then that's when the patient really becomes vulnerable. And I think that's when we can teach them that, yes, we use medications to modulate that, but there are other things that you can do behaviorally to modify that as well. And this essentially is looking at functional imaging of brain to show the changes. There can be structural changes. Again, during attacks, basal ganglia can be activated. You can see changes in the putamen. Again, here's hypothalamus, so caudate nuclei. So you can have both cortical and subcortical structures that are involved during migraine attacks. And again, there can be specific changes to the brains for women. But what we know is that we really want to preserve and encourage this homeostatic place for brainstem. And we want to avoid cortical spreading depression. We want to avoid initiating attempts. And by changing that threshold, we may be able to do that. This essentially, and I think Mark Green has shown you this, it's essentially looking at passage of cortical spreading depression through the brain. And there are many brain areas that express calcitonin gene-related peptide, those that express those receptors. And of course, these are the targets for the upcoming 4 compounds that are being looked at for prevention. So I think one of the things that's extraordinarily exciting about migraine is that as we understand the pathophysiology increasingly, as we think about prodrome and those odd prodromes of food cravings or overwhelming fatigue or yawning, those sound like craziness, don't they? But as we increasingly understand the pathophysiology of migraine, we know that those are really under hypothalamic influence, and this homeostatic mechanism, which is beginning to change its homeostatic or its tone. And then as we continue to understand essentially the neurotransmitters and the patterns of transmission that are involved in that, we can increasingly begin to direct both acute and preventive strategies. And again, most of the new work here is going to be looking at monoclonal antibodies to really try to stop the role or to reduce the pro-inflammatory effect that calcitonin gene-related peptide release has on the promulgation of migraine. So when we think about hypersensitivity, you can see all the images are rather unpleasant as we look at these pieces, but I think it's important to think about hypersensitivity maybe in the context of enhanced sensitivity. And what can we do as clinicians to teach patients about their enhanced sensitivity, their hypersensitivity in effect? It I think really becomes very important as we think about the model, that the model really includes some basic understanding of the pathophysiology of migraine and this enhanced hypersensitivity of the migraine brain, and how patients can do specific things that will help restore homeostasis and reduce their enhanced hypersensitivity, And then how we as clinicians can direct and support that and also provide them with medications that can reduce it from the beginning. So in conclusion, I'd like to have us think about treating the patient's illness and not their disease. And the semantics don't matter so much, I think, as long as we get a model of patient-centered care, so that patients really understand what their diagnosis is, how we arrive at it, so that they arrive at it too. And we do things both from a behavioral and a medication, a pharmacological, and an educational standpoint that reinforce that original diagnosis. We need to individualize management, again, stratified care, and think about treatment choice based on attack frequency and severity. Do they vomit or not? Do they have hypersensitivity to light and sound, to smells? Are they disabled with attacks? What have they been on before, and was it simply used incorrectly, delivered incorrectly, or is it not the right choice? Was it too low a dose? And how to walk the patient through a retrial or a new trial, and really work with them about their willingness to take medications and being patient with them and trying to hear that they bring to us when they come to us their very often very long history, sometimes an unpleasant one, of bad experiences with medications. Comorbidity and coexisting conditions are where we can absolutely change lives, because if we don't treat the comorbid conditions, we will never get the patient as successfully treated. And this is about successful treatment of the entire patient, not just the migraine. And then we need to realistically assess with them and continue at office visits to go back over and emphasize and work with them on the basis of their ability to modify their sleep, diet, hydration, caffeine, and begin to exercise. The model, I think, is therapeutic partnership. I think it's based on the science of migraine. It's based on what really is happening in brain. And it's really based on how we as clinicians and patients come to that and design treatment plans that include pharmacology, that include behavioral health, and that include the treatment of comorbid conditions and of hormonal states that can allow patients to feel well and keep their brains as homeostatically stable as possible. Thank you.